What are the presenting complaints of a patient with acute osteomyelitis? There will be acute pain, as there is acute onset of pain and swelling at the end of the bone associated with systemic features of infection like fever. Often the parents attribute the symptoms to an episode of injury, and the injury may be coincidental. Now, how will you examine this patient? The child will be febrile and dehydrated with classical signs of inflammation localized to the metaphyseal area of the bone. In later stages, one may find an abscess in the muscle or subcutaneous plane. There may be swelling on the adjacent joint because of either sympathetic effusion or concomitant arthritis. Investigations. So first of all, we'll do blood investigation. There may be PMNL seen, as there may be polymorphonuclear leukocytosis and elevated ESR because there is an infection. A blood culture at peak of the fever may yield the causative organism. X-rays. The earliest sign to appear on the X-ray is a new periosteal bone deposition in the X-ray. That is also called as periosteal reaction at the metaphysis. It takes about 7 to 10 days to appear. And lastly, we can do bone scan. A bone scan using technetium 99 may show increased uptake by the bone in the metaphysis. This is positive before changes appear on X-ray. This may be indicated in a very early case where diagnosis is in doubt. Indium 111 labeled leukocytosis can be the most specific for the diagnosis of bone infection, so that you have to remember indium 111 labeled leukocyte scan. Now, what are the DDs for acute osteomyelitis? First is acute septic arthritis. This can differentiate from acute osteomyelitis by the following features like tenderness and swelling localized to the joint rather than the metaphysis, and movement at the joint is painful and restricted. Acute rheumatic arthritis. The features are similar to acute septic arthritis. So we have to see the elevated ASLO titers and CRP values in acute rheumatic arthritis. Scurvy. In scurvy, there is a formation of subperiosteal hematomas in scurvy. So they may also mimic like acute osteomyelitis radiologically, but there is no pain, no tenderness and fever joints in scurvy. Or there may be acute poliomyelitis. Then how will you treat the patient? If the child is brought within 48 hours of onset of the symptoms, it is supposed that pus has not yet formed and the inflammatory process can be halted by systemic antibiotics. So treatment consists of rest, antibiotics and general building up of the patient. The limb is put into rest in a splint or by traction. Choice of antibiotics vary from center to center and broadly depends upon the age of the child and choice of the doctor. In less than 4 months of age, a combination of ceftriaxone and vancomycin in appropriate dose is preferred. In older children, a combination of ceftriaxone and cloxacillin is given. As the child improves, the limbs can be mobilized. Weight bearing is restricted for 6 to 8 weeks. So first of all, we have to remember that antibiotics are taken and are started after taking blood for culture and sensitivity. Antibiotics are changed to specific ones depending upon the culture and sensitivity report. And the child will be adequately rehydrated with IV fluids Response to the above treatment is evaluated by frequent assessment of the patient. A 4 hourly temperature chart and pulse record is maintained. It is good idea to outline the area of local tenderness precisely. If the patient does not respond favorably within 48 hours of starting the treatment, surgical intervention is required. If the child is brought after 48 hours of onset of symptoms, then detection of pus is also difficult, as there is collection of the pus already inside the bone. So an ultrasound examination will be helpful of the affected part, as it can detect the deep collection of the pus. And surgical exfoliation can also be done, and drainage is the mainstay of treatment at this stage. A drill hole is made in the bone in the region of metaphysis. If pus wells up for the drainage is obtained, a swab is taken for culture and sensitivity, and antibiotics are continued for 6 weeks. The complications are there may be general complications. In early stage, the child may develop septicemia and pyemia. Either complication, if left uncontrolled, may prove fatal. So you have to remember that the child may develop, if not treated, septicemia or pyemia. These are general complications, but the local ones are chronic osteomyelitis. It is the commonest complication of acute osteomyelitis. There are hardly any radiological features in early stage. A delay in diagnosis leads to sequestrum formation and pent up pus in the cavities inside the bone. Poor resistance is another reason for the chronicity of the disease. Acute pyogenic arthritis may also be there. This occurs in the joints where the metaphysis is intra-articular, example the hip, the shoulder. And pathological fractures, this occur through a bone which has been weakened by the disease. Or growth plate disturbances may also occur. Thank you.